Hi, everyone. Thank you all for joining us for this webinar, which is part of our series of presentations that are focused on applying evidence into practice, which is part of our comorbidity project funded by the Australian Government Department of Health and Aged Care. My name is Christina Morell. I'm an Associate Professor and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. Along with Alexandra Azzi, who is a project officer on this project, we are back here again and very pleased to be facilitating today's webinar, which is being presented by Dr. Eddie Mullen. Before we start, I'd like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we are meeting across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal peoples of the Eora Nation, but I would like to acknowledge and pay my respects to the traditional owners of the lands across Australia for everybody else who is here, and pay my respects to elders past, present and emerging. And I extend that respect to any Aboriginal and Torres Strait Islander peoples who are here today. I'd also like to recognise and acknowledge the many people with lived and living experience of mental illness and substance use, as well as their families, carers and loved ones, many of whom have so generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. Just briefly, whether you're joining us live or watching the recording later, you're all in listen-only mode, which means we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Eddie during the presentation today, please feel free to type these in using the Q&A button. If you have any comments or anything other than questions for Eddie, please use the chat button. And this just helps Alex and me keep track of what questions we pass on to Eddie and whether there are any other requests for support or technical issues that we need to assist with. Both the slides and the recording for this webinar will be available for download from the website in the next couple of days, and the link to access that is on the screen there. So today's webinar is on neurodiversity and substance use, and I will hand over to Eddie in a moment. But just before I do, I want to mention that you can access our webinar library. The link to do that is on screen. We will be having more webinars over the next few months, but the next topics are still to be decided, so I can't tell you what those are yet, but you can subscribe to be notified about them and to find out what they are when they're available by clicking on the link that Alex will post in the chat, or just have a look back at our website from time to time. And to thank everybody again who's been coming along to this series, either watching live or with the recordings later, sending through any feedback and suggestions for webinars. As with the last couple that we've had, today's webinar has been organised in response to some of your feedback. So thank you again for coming along and engaging with us. If you do have time, please take a minute at the end of this session to send through any suggestions for what you'd like to see as part of this series, or you can email us and we'll continue to see what we can do. So now it's my great pleasure to introduce our presenter for today, Dr. Eddie Mullen. Eddie is a youth psychiatrist and has been at Orygen Specialist Program in Melbourne for over 11 years. He's the Director of Medical Workforce and co-lead of the Orygen Youth Addiction and Dual Diagnosis Stream and Substance Use Research Group. He has a strong interest in understanding developmental perspectives of substance use from early adolescence into adulthood, and how this can inform our approach to screening, assessment, and offering evidence-based treatment, as well as the intersection of youth, neurodivergence, and addiction. I'm so very pleased that Eddie could be here with us today, so I'll hand over him to get started. Thank you so much, Eddie.
Thank you so much, Christina. I will try and get the screens up and running. Right, short and sweet. So thank you very much for the introduction. As said, my name is Dr. Eddie Mullen. I use he, him pronouns. I'm a youth psychiatrist with an interest in addiction and neurodivergence, as well as personality disorders. And first, a big thank you to the University of Sydney and the Matilda Centre for inviting me along today. I find it an honour to be able to present on these things and sort of have discussions with the broader community about these areas of need and interest. I'd also like to acknowledge the traditional owners of the lands. I come to you from Parkville in Melbourne, which is the lands of the Wurundjeri people of the Kulin Nation, and pay respects to our elders past and present, and also just acknowledge the enormous contribution and importance of lived experience in informing and also sort of contributing to the work that we do today. No conflicts of interest to declare. Just some acknowledgements as well at the start. I'm mindful this area is a complex area, and there's a lot of really important people who work in this area and who contribute to the discussion we're having today. And And very much so, not only do I've been taught and work with some great people down here in Victoria that have informed my positions, but also have borrowed a few of their slides. So I very much wanted to acknowledge, and particularly Sandra Radavini from Mindful and Catherine Cox and Dave Coghill from our neurodevelopmental stream here at Orygen, as well as my youth addiction and dual diagnosis stream sort of colleagues. Purpose of the talk today is really threefold. It's really, it's a complex area. We all see it in our clinical field. We see it out in the community, and very much no one is the expert here except for those with the lived experience. And what I encourage us to do today is really just consider kind of thinking about sort of where substance use and where addictive behaviours come from. As a youth psychiatrist, I think I will be kind of focusing more on the younger age of the spectrum and very much thinking developmentally, and then very much kind of thinking about, how does our understandings kind of map onto neurodiversity? And neurodiversity very much today is sort of more broader, I think, in terms of the autistic community, as well as those with ADHD. And also kind of maybe reflecting more on the opportunities and challenges for us as clinicians, as people, as services who want to kind of help and want to provide kind of appropriate settings and interventions for people who are accessing care. I'm thinking a little bit about my journey. By no means do I consider myself an expert in this field. I think, as I said, I'm taught and guided by others, and very much so I'm taught and guided by the young people and their families who I work with. And for me, it's been a long journey over kind of 10, 15 years of kind of working with a variety of young people and adults who've come for treatment in hospital settings and community settings and different areas, and really realizing I need to learn more, and I need to bring that learning to my service and think about, how are we helping the group of young people and adults with neurodiversity and substance use issues? Because I'm not sure if we do it that well. I'm not sure if there's a huge amount of great answers out there in the literature either, but how do we kind of bring the discussion to thinking about how do we consider things, and how do we offer care to people, to really wanting to personalize and improve care? So what do we know so far? So I'm going to talk about a few issues. Interesting, neurodiversity is such a huge space, and addiction is such a huge space. How do we break it down? So what I've kind of done is, so it builds on a talk I've done sort of last year for VADA, which is the Victorian Drug and Alcohol Service for neurodiversity, about thinking, what do we know so far in the groups? And apologies if I'm kind of recapping stuff that's well known, but I thought it's good to set the context and the scene in terms of what we know so far in terms of neurodiversity, but also in terms of addiction. So when I talk about neurodivergence, it's a very broad topic. It is a spectrum, but for the purpose of this talk, we only have about sort of 40 minutes, 50 minutes. Geez, you could speak for days and days on this, and there's whole conferences and symposiums dedicated to stuff. But I'm going to talk about two main areas, definitely those from the autistic community, and a little bit about ADHD as well, really maybe thinking about earlier end of the spectrum and ADHD and how that maps on. Autism itself, we know that autism is changing a lot in terms of how we consider. It used to be considered previously as something quite rare that occurred in childhood, was associated with a lot of disability and speech and language development issues, and was quite distinct from normative development being a disorder. Whereas these days, I think we have a more nuanced view. We understood that kind of as a spectrum, it's relatively common in terms of the community there, and those accessing care can be present across the lifespan, and those disabilities. A lot of people who have autistic sort of symptoms or features really, this can be associated with quite normal range IQ, and it's maybe a more natural form of human variation rather than a disability, and rather than sort of a disability view, things that actually being in the autistic community can bring both strengths and challenges to those people who are accessing care that we're talking about today. What we do know is there has been an increase in diagnosis over the last kind of couple of decades, and this is kind of a topic, and sometimes it hits the media when this is some UK data, but rather than it's something that being kind of think about why the rates, maybe our recognition of some of the challenges, some of the strengths in the autistic community is improving, maybe access to services, maybe some of that public health campaigns are getting there, that more and more sort of young people and even adults are recognizing that they're seeking treatment, seeking assessment, and seeking diagnosis to help them kind of understand their own personal experiences, but also to kind of try and access care, and particularly in Australia, looking at things like for those maybe needing NDIS support as well. So there's been an increase in care and increase in recognition in the community. And when you look at those who are diagnosed, that very much so still we look, I mean, the stat is a little bit older now, but we look at sort of a lot of those recognition and diagnosis still occur earlier on. That's being picked up earlier and earlier in sort of younger years in child and adolescence, but also kind of recognizing that there is a tail end, there is a lot of young people, young adults, and even older adults who have not been picked up in school or earlier on, and go back and maybe seek diagnosis later on, due to awareness. I'm thinking about when we, for us, I'm told that primarily a lot of this is a clinical kind of discussion. A lot of people are clinicians from a lot of different fields who are accessing the talk. We know that, in fact, we look at sort of autism across the spectrum, that it's not just the one thing. That we know that there's a whole co-occurrence, and co-occurrence is the reason we're here, really. Co-occurrence is the norm, I would say, working in mental health or in addiction, that we do know that people who are coming for care really do present with not just neurodevelopmental issues, but also a lot with high degrees of sort of trauma earlier in the history of ongoing trauma, with sort of troublesome sort of physical and mental health problems, and with addictive fields. So what we know is we kind of have some guidelines that are in different fields in terms of working with autism, working with trauma, working with mental health disorders, working with addictions. But very much when you get that intersection, our confidence in what we're doing and the knowledge that's out there in terms of guidelines and kind of evidence base it gets much more scarcer and not known. I suppose that's why we're here today talking about this space. And also just mindful that we do need to be aware of the lens in which we view things. I think I work in a mental health program, and I'm very mindful. I see things through a mental health lens. I've done training through a more traditional alcohol and other drug program. I'm mindful that they saw things through a lens, and so it's been understanding that we all come with our own perspective, and things like chances like these to get together help us think more broadly outside of kind of where we work. Autism spectrum disorder itself, we know it's a neurodevelopmental condition, affects an individual's development and social communication, and we kind of see some of the problems occur or strengths occur from early childhood. And using DSM as kind of a diagnostic tool, we look at those two domains really in terms of challenges in social communication, and also kind of behaviours and stuff that might arise, or thinking that might arise from restricted and repetitive behaviours. And what I hope to do today is think about how that maps onto addiction and treatment. We have other ways of looking at autism, kind of these are some good slides from Sandra Radovini, who's lectured a lot of this in Mindful, kind of when we talk about autism spectrum, but people always taught spectrum as this thing between either not autistic or very autistic, whereas actually in truth, we know the spectrum is much wider and diverse, that no one has the same brain, that everyone has their own kind of strengths and challenges, and looking at things really from the different traits or the different features that each individual person brain some things will create difficulties, some things people will be stronger in, really looking at things in its broader. I like the colors as well, being a rainbow, really kind of thinking about all the different domains and all the different kind of areas, and that things not just being dark and bad, but also can be strengths as well in someone's lives and can be useful in day-to-day life. So also kind of think about just the differences in terms of how we deliver care, that, just because you've met one person with autism, you haven't met you've only met one person with autism. Not everyone who's different is autistic. That really kind of what we look for really in terms of people being individuals. And as clinicians, we kind of maybe our general skills that we kind of do is kind of maybe thinking about how we work in the mental health or addiction field. We kind of look for patterns of things that we're looking for when we're kind of diagnosing or suspecting or formulating. Oh. But also kind of maybe how do we look at those kind of features or patterns? We're really looking for those combinations of things. We're looking at from some of the core features. We look at the autistic community about this. We talked before about sort of social language or deficits, some sort of kind of behaviors, sort of restricted range of interests, ability to regulate emotions, some sensory difficulties and sensory hyper and hyposensitivities, which we'll talk about are important in terms of how we deliver care. We look at kind of people having kind of masking or camouflaging being terms that are used for compensatory mechanisms that developed over a lifetime potentially to try and fit in or blend in or look normal. And we do know that people from the autistic community might have a lot of co-occurrence in terms of being at more at risk of developing co-occurring mental health conditions. We talk about addiction as well, or substance use disorders, and even other neurodevelopmental disorders. some of those dimensions that I talked about. Looking at this is a nice diagram. It kind of maybe talks about some of those domains where you might look at stuff in terms of mood symptoms, anxiety symptoms, different domains of focus and intention, intelligence, processing, interests, routines, and social interaction and communication, and kind of really bringing together a bit of a personalized understanding of the person in front of you, as kind of individual expression of what they experience. And also knowing that actually, you know, what we talk about, beware what lens you work in. As I said, I work in addiction field, and I also work in the personality sort of fields. And I've a habit. I'll out myself and say that I do get caught sometimes, and bringing my lens to things, but knowing that in the autistic community is the great imposter, that, kind of core features of autism do mimic other things that are more mental health diagnosed, like social anxiety, or I would argue all personality disorders, or repetitive behaviors, often being maybe misdiagnosed as OCD or Tourette's or other things. So just acknowledging that's the great imposter, autism. And thinking of other areas of trauma and psychosis that might be better explained by sensory deficits, things like speech and language kind of difficulties, and this emotional dysregulation. Thinking a little bit about switching to ADHD, because we want to focus on that. We know that ADHD, it's definitely, since I started being interested in the field, the interest and kind of interest from the community, but interest from the profession in terms of understanding and screening, assessing ADHD has exploded. That we do know that ADHD can be a combination of both inattentive symptoms and hyperactive symptoms, and can be as simple, can be things like staying on task or being distractible, losing things. I always argue, I feel very aligned with some of this stuff myself, and in terms of organization and losing things, but also kind of that hyperactivity or impulsivity presentation. And we see these symptoms kind of, what the key thing of ADHD is, being present quite early in terms of childhood, and either, I said, young people being picked up early, or maybe when we talk about adult kind of retrospective diagnosis, recognizing throughout the age range that these things were present from an early age and continue into adult life. Because what we are seeing is that actually the acknowledgement, and thank you, David Coghill, for sharing some of these slides, that when we talk about ADHD being a high prevalence or low prevalence disorder, that it's actually quite common. When we look at different samples across the world, really, that up to 5 to 7% in children, adolescents, and the prevalence, and compared to other things like schizophrenia or bipolar, which are quite low prevalence, it's definitely up there. And when you look at an adult sample, 2.5% being a reasonably conservative estimate of diagnosed ADHD in adults. Some of the controversies about, are we increasing in time? Is it there? When actually you look at several decades worth, that actually looking at prevalence estimates across 3 decades, I mean, I think it's been reasonably consistent across the years. It'll be interesting to see how this data holds up. But I would argue that, in fact, similar to maybe what we've seen of the increased awareness of autism, the last sort of 5 to 10 years have brought an increased awareness of ADHD as a syndrome that causes a lot of disability, and maybe under-recognized in youth and in pair adults going forward as well. What we have though seen is definitely, we've seen, and maybe it's a result in terms of kind of increased awareness or increased familiarity, we have seen an increase in prevalence of medication prescribing across the last decade, and that mainly been led by the private sector and paediatricians, especially in the Australian context, but more and more demand being in, particularly I work at Orygen, which is the tertiary public program for youth mental health, but very much an increased expectation from families and young people that as a public service, we're also able to kind of consider ADHD as a diagnosis, and if so, sort of treat as well. So I'm thinking about why it's important. I think this is sort of, I said, not to labor the point, I said this is a whole kind of, there's a whole extra symposium or talk in itself, but we do know actually that having ADHD itself can lead to a lot of sort of difficulties in school, difficulties in functioning socially, vocationally, in terms of kind of issues in terms of seeking work, and in terms of getting in trouble with the law. And what we do know is that undiagnosed ADHD, if untreated to adult, actually does lead to functional problems that persist. Adults might have higher rates of crime, higher rates of substance misuse, which is what we're talking about today, and also potentially higher rates of co-occurring psychiatric disorders. So quite an important thing to consider, whether it's there early and picking up and treating. think about substance use and just more to set the scene. What do we know about substance use in young people? Well, firstly, terminology is important. I was at a recent conference, and this was a big topic in terms of addiction physicians and specialists, that really we use a lot of terms interchangeably in the field. And kind of for today, I'm sure I will as well. It really depends on what type of research you're presenting, but just to differentiate, and I think from a developmental point of view as a youth psychiatrist, that substance use can be quite normative, that using alcohol on a weekend or sort of maybe smoking a cigarette can be a normal thing using substances. One might argue that even, trying experimenting with different drugs with friends, going out can be useful. But when does that become, that's different to substance abuse or substance misuse being a terminology, when it starts to cause a problem versus when it's become quite problematic and become a disorder. So very much in terms of not sort of pathologizing normative human behavior, just kind of, I think it's important that we kind of think about the terminology that we're using when we're describing these issues. I'm thinking about sort of normal developmental stages in young people, that actually, on that note, that there is a spectrum of use or kind of development in young people, that quite often young people, experimental use of anything, of any type of behavior is quite normative for young people. Young people tend to be quite curious. They tend to be quite novelty seeking, and they like to take risks. That's not pathological. That's a normal part of teenage years and thereabouts. And I'm thinking about when that kind of use with friends is there. And then also when as adolescents get a little bit older and they're exposed to more peer influences about kind of using substances as a means to kind of socialize, in terms of social events, in terms of fitting in terms of kind of connecting with others. And so this has made the worry in these exposures. Doesn't become this gateway period, as they say, when kind of the use can become more problematic and things become instrumental, as they say, that actually this is at the stage when young people or us might learn that actually use of different substances might be a way to manipulate your affect, actually to achieve, if I'm feeling down, I might feel better. If I'm feeling very anxious, I might feel more calm. If I'm feeling very nervous about going to the school disco and meeting people of the opposite sex or same sex for the first time, it makes you feel better. Kind of using it then to affect my behavior. If I take these stimulants, I'm great fun and I can go to the 24-hour rave. And in fact, things are pleasurable as well. That's mostly people take things because they're fun, so learning how to use things instrumentally and really thinking this is when we start to head into the problematic way, that things might become more habitual. When you learn to use things instrumentally, you might become potentially a risk of relying on them and relying on that instrumental use to manipulate affect or to socialize or to fit in, that I need these things to cope then, and I need these things to go out, and really then heading into the higher levels of substance use disorder when things become quite compulsive, when that habitual use becomes everything, when the salience, when sort of achieving those states and using substances achieves salience where it sort of takes over your life, when you start to see the harms start to be associated with it, when you're missing out in school or relationships or work or getting in trouble with the law. And what we do know is that these things kind of do increase usually with increasing age. The older one gets, the older might be more exposed to harms, and the amount of substances and the number of substances increases, and the risk of severity then of substance use disorder increases. That actually the age of onset, that we know that most substance use, not being problematic use, but use in general, starts in adolescence. And the peak onset being around 18 to 20 years old. And actually maps on nicely to the peak onset of mental health disorders and stress as well. And those with those co-occurring mental health disorders and substance use disorders might do worse in terms of that age group. So think developmentally about, we're looking at sort of early teens to late teens into early adulthood. What substances do we use? Yeah, we use kind of things like this. This is a great website. I encourage it. It's called Harm Reduction Victoria. They do a fantastic website and all these kind of brochures with every kind of type of street drug that's out there, with helpful tips about what nicknames are there and what they're called and how they might be used. So I do encourage people, if you're looking for resources, I'm sure there's other ones. There's other ones in New South Wales as well. There's ones in Victoria. There's ones in every state, but Harm Reduction Victoria being a particularly good website. I like to go to this one. But really thinking about sort of why do people use substances? More to the point, don't forget the reason people use substances, all those is usually, if you look at the data for youth populations, it really is either A, for fun, B, for social connection, or C, to manipulate affect or cope with negative emotions. Substance use disorders, very boring. This is the DSM stuff. Just to kind of round out this topic. So I've talked a little about normative substance use. I've talked a little about when substance may be misused, but when something becomes a substance use disorder, we still use DSM to kind of diagnose and really thinking about is something problematic? Does it cause problems? And these diagnoses, I think, are reasonably valid in terms of something a mild, moderate, or severe substance use disorder, about that sort of loss of control, that causation of problems, and that increased salience in terms of use. So we look about these would be the standard criteria for DSM, and very much looking for kind of physiological changes as well and harms associated with. We all kind of know about things like what used to be called dependence, but looking for things like tolerance and withdrawal. So getting into other things. So this never gets mentioned as well. So substance use, I'm not going to talk a lot about it. This is a whole other section itself, but also the forgotten behavioral addictions. So things like the internet, things like gambling, things like gaming, some examples there of what's there. And particularly, this is very interesting because these are also things that are socially acceptable these days, particularly in Australia. I think of legalized gambling and sports betting. How do we differentiate between what is normal use and what is problematic use? And I'm very much thinking I'm going to talk a little bit about kind of in this neurodivergent sort of young people, autistic community and stuff, where a lot of people, this might be quite normative, or maybe increased levels of these things may be normative because of kind of few issues. And when do things become problematic, and how does that affect kind of how we understand and how we offer people interventions in this space? So substance use and autism. Getting there. So the old view, there used to be an old-fashioned view about autistic individuals. They used to talk about actually autistic individuals were protected from developing addiction and substance use problems. And it really be because if you were an autistic individual, you were more rules-based and flexible in your rules and less likely to break the law. You were less likely to have social interactions and be in those sort of peer influence spaces. And when you were there, you were less likely to be peer influenced. That's a very old view and a quite a reductionist view, I think, and an old-fashioned view. And we know that is not the case, in fact, that, when you look at some of the recent trends in terms of addiction, that individuals with autism are actually more at risk in some of the literature, twice as likely to develop an addiction problem than some of their non-autistic peers. And in fact, a lot of those people seeking substance use probably had an autism diagnosis, and in fact, as high as some of the studies have looked at, as high as 1 in 5 teens and young adults receiving substance abuse treatment in different settings may have undiagnosed symptoms of autism. And really, so this is all from this Lancet paper by Weir. And there's a good quote. I said, amongst those who would have provided any information regarding their motivations for drug use, thinking about this group, autistic individuals were nearly 9 times more likely than non-autistic individuals to report using them to manage behavior specifically. So when we think back to some of those reasons we presented about sort of the developmental reasons, but also the reasons for use, already thinking about in our minds how some of an autistic individual some of those things might map onto some of those features of autism in terms of kind of coping and social communication, but also repetitive behaviors. And that individuals described using drugs to eliminate, control, or reduce autism or symptoms of autism and other comorbid symptoms. And the Society for Study of Addiction, and even as 2021 was really coming along as thinking that actually autistic individuals might be more at risk than others in terms of how they use instrumentally or that use. And thinking of the use, so just to kind of finish out that, really thinking, are reasons for use in autism different? I mean, some points that come from some of those literature really fitting in being an important thing, that actually kind of, we know more people, young people and adults are across the spectrum, are kind of more engaged in study and workplaces and relationships, that actually kind of fitting in, using substances as a way to fit in, being a peer-led thing or being a social thing is present. That actually masking being a thing, that actually kind of using substance being maybe a way to kind of mask the symptoms of autism in terms of some of the awkwardness and social communication deficits, or kind of some of the repeated behaviors that using substances instrumentally might be something that people learn. Also, we know there is a strong overlap between autism and social anxiety, and using instrumentally, again, using substances particularly as instrumentally to modulate affect, to manage social anxiety, could be a risk factor. once again, instrumentally, that feeling very overstimulated in environments where social environments or other environments, that actually learning to kind of use substances instrumentally to manage anxiety symptoms or symptoms of overstimulation is a risk factor for autistic individuals. Repetitive behavior is an interesting one, and we'll talk a bit about that, because I think one of the overlaps in terms of autism is in terms of sort of engaging in sort of inflexibility or repetitive behaviors is really maybe finding something that works. That if I use something that I know helps with my social anxiety or helps me fit into situations, or if it makes me feel a little less overstimulated, that I'm more likely to use that again if I get a pleasurable response or a positive response to it. And are autistic individuals more at risk because of the tendency to engage in more repetitive behaviors once you find something that works, to continue doing it, is it also a risk factor, maybe more resistant to standard treatment methods? That's very hard to shift out of something that works without anything to replace it. In autistic individuals, definitely from my own clinical experience of work in the field, I know that's a conversation I like to have early on. And also kind of, are there things that help you focus? I'm thinking in things of kind of, is it being distractible and things of kind of being overstimulated? Are there other things you can use instrumentally that help you focus in a situation, things like stimulants or other drugs that help you focus? And can I use things to help manage emotions that I've referred to previously? So a couple of points for thought. As I said, the literature there is stuff out there. I said in the last sort of decade or so that they talk more about these things. Some of the addiction societies, some of the papers that have come up have really talked about thinking about autistic individuals and thinking about some of those unique strengths and challenges, that how would that map onto how we understand some of those behaviors associated with addiction in particular. And talking about those behavioral addictions, really, that are talked about, quite a kind of, when I work in the youth field, I see a lot of young people who have diagnosed autism or suspected autism who really have very limited social interactions outside the home, and in particular like online engagement, online gaming, League of Legends, sort of these things. Multiple online battle games or RPGs and stuff are the way that they actually access social communication and actually kind of converse and interact with people online. And kind of is there something about doing that and that repetitive behavior and that positive social reward, and particularly these things, and when does that combine with a loss of control? Does it cause another level of intensity in terms of the risks of developing behavioral addictions? Particularly, I talked about internet addiction, but thinking more broadly about stuff like gaming or gambling as another potential risk factor. That's a whole other topic. So that's another webinar. There's other research in this field. Particularly, I'm thinking of some of the work that comes out of Monash Swinburne University down here that would talk about that. Substance use and ADHD. So this is the other broad topic of why we're here. This is a slightly controversial field. I know there's people with very sort of strong and passionate and correct views on both sides, and a view from the community as well that, ADHD is and substance use disorders. Once again, I talk about substance use disorder here, not normative substance use, but the evidence would overwhelmingly say that ADHD is a risk factor for development of substance use disorder. Particularly if ADHD is untreated. People presenting to services with substance use disorder have increased risk of having ADHD. That's sort of either diagnosed or undiagnosed. I think I can definitely understand that from my clinical work. People looking at some of the clinical samples, they talk about people with ADHD are almost 3 times more likely to be nicotine dependent than non-ADHD, and 50% more likely to develop a drug or any drug or alcohol use disorder than individuals with ADHD. And think about treatment settings. A lot of people don't present. As I said, very hard to present for an ADHD assessment or to a public service where that might be the presenting issues. A lot of people may present to addiction treatment settings for treatment of addiction issues, but those presenting with primary substance use disorders do demonstrate an increased prevalence of ADHD compared to the prevalence of ADHD in the population. So I've put some references in there if you want to look at the papers. The associations, so from Dave Coghill's side, there's the association, there's a lot of postulated things out there in terms of kind of the kind of what is the association without being there, but You know, we talked about some of the routes into substance use, substance misuse, substance use disorder from a developmental perspective, but that novelty seeking and high stimulus and impulsivity behavior being a feature of adolescence, but also as a feature of ADHD, and kind of it's one of the inherent features of ADHD, and kind of doesn't maybe mellow out over time. But that's a risk factor as well, and is there some shared genetic risk between substance use disorders and ADHD because of those factors? That impairment in terms of ADHD and being less likely to, in terms of meaningful social relationships, of academic achievement, and being able to function at work and hold down jobs, being a risk factor for developing a substance use disorder as well. But also kind of similar to what we talked about the autistic individuals, that actually maybe does substance misuse, substance use disorder provide some relief from the symptoms of ADHD. And I think this is very commonly, I think I come across as clinically as saying the self-treatment of symptoms. Yeah, I self-medicate with methamphetamine because I'm always on the go and it helps me feel clear. And the first time I ever felt better when I was smoking some meth and stuff. And that's quite common. And is that a pathway? We talk about the self-medication pathway or coping pathway in development of substance use disorders or dependence. That how do people learn to use instrumentally and then habitually and then kind of compulsively in terms of self-treating the symptoms, things that relax you, like cannabis, like alcohol, and things that might help you focus, like some of the stimulants like cocaine and methamphetamine. And also this co-occurrence of conduct disorder as a child, being a co-occurrence of ADHD, but also being a risk factor for developing a substance use disorder. So thinking about some of those associations when we're considering the person in front of us. So next, how can we improve our services? I mean, this is a good one. So as I said, I think I'll set the scene a little bit about terms of ADHD and substance use disorder, but very much kind of thinking about maybe talking more about sort of, I do this talk mainly in terms of autistic community in terms of ADHD, but I think it equally applies both profession. Simon Baron-Cohen, who's a very well-known researcher from the UK, who is actually related to the other Baron-Cohen. So it's essential that we ensure that autistic people, I'd argue all neurodivergent people, have equal access to high quality social and healthcare that can appropriately support their specific needs. And unfortunately, it seems our current systems are still not meeting the mark. This is from the UK. I'd argue this is the same across the world. Having seen our local context in Australia, having, as I said, been at an addiction conference region, hearing the same challenges across the world. I think we'd all agree. How do we do it? What is the problem? How do we identify when someone has a problem? And we know that kind of, we're very split. We talked about that lens earlier. If you work in an autism service, I was going to say there is no such thing as an ADHD service, but if you work in a service, maybe an autism or a disability service, that you can identify addiction issues or issues with substance misuse or substance dependence, but clinicians who work in those things feel very unskilled in managing those issues and quite often seeking referral to services that they get bounced back out again. We know it's quite hard to actually access services. And similarly, if you work in an addiction or a mental health service and we're guilty as charged, that definitely we rarely screen autism, we rarely screen ADHD, that we think that people, if they're not engaging in treatment, in standard treatment, they're being difficult or they need to be discharged, that this not being able to respond to treatment is a failure somehow of the person accessing treatment, as opposed to kind of not identifying the problem earlier enough and understanding how we adapt care. What we do need to do, we need to personalize. This is kind of that quote earlier. We need to attune to the individual. People are people. There's no such thing as the autistic, that everyone is different. Everyone has their own strengths and weaknesses. We need to kind of get on the person in front of us as much as we can. We need to think about how we communication, standard things like sending text messages, phone calls, might be quite letters. Might be quite difficult for someone an autistic individual to actually respond to because of the nature of maybe some of their challenges. And I would argue as well, now I've worked with young people with ADHD for some time, trying to get them to appointments and respond to letters in a timely way is nigh on impossible. So thinking about the way we normally communicate, the secretary sends out a letter, or you didn't get that letter, you didn't come to the appointment, really is a barrier to care. And also the environments that we're providing care in. Particularly in the addiction setting, which is kind of quite reliant on group processes and treatment and settings, can be quite a barrier in terms of accessing care or succeeding in understanding the person. I teach and present a lot in youth. This is a good thing from the RACGP. This is a tool we call HEADS assessment, and it really is thinking more formulation. Who is the person? It's not just a problem. person's not just addiction. We need to, where do they live? What do they do? How do they eat? What's their physical, sexual, reproductive health? What's their history of self-harm? What's their social media use? You know, all those things. What do they do for fun? Yeah, understanding the person themselves. And these type of tools help us bring a more robust kind of holistic view of the person in front of us. You know, we obviously take a harm reduction approach. You know, we all know what harm reduction is. Abstinence may not be a realistic or achievable goal for many people. Particularly, we talked about the challenges if these things are the only things that have worked over time. But, you know, actually kind of thinking about what is achievable. Harm reduction is doing things, but doing things more safely and kind of providing that kind of empathic, non-judgmental space. What I would suggest is we need to be screening. We need to be the people who are presenting for care to us. We need to have some good screens for both. We have some screens for, if we're looking in an addiction service, we're pretty good at screening for substance issues and behavioral, maybe addiction issues, but we need to maybe think about what are some screens that might pick up some of the difficulties if we're there. There's some very simple ones that are out there. I can include them in the literature. Geez, I could do a whole few slides on this, but there's simple patient reported, you know, that some that might be there that might indicate further assessment is needed. You know, do we have the skills to assess ourselves in-house, or do we need to kind of engage, you know, sort of experts or refer out? You know, is it going to be useful? Can we take this formulation of a person in front of us in terms of who they are, what their strengths are, what their challenges is? Can we plug it into our formulation and take into account some of these things that may occur because of neurodivergence? And when we put our plans in, can we actually modify? How modifiable are the plans of how you get care, how frequent it is, what you need to do to get care to account for your difficulties? So I'd argue this is what we probably all do anyway, and it's just putting down in paper, but really kind of stressing if we're not screening, we're missing a chance to kind of pick up on things that we might come into later. Treatment challenges themselves. This has been the traditional setting maybe for a group program or a residential rehabilitation facility or stuff. You can imagine how terrifying this would be for anybody with maybe it might be an autistic community to sit in and open up in front of their individuals, or even to sit still for an hour or two with someone with ADHD. They'd be bouncing out of their seat, or stay focused might be perceived as rudeness or inattention. So the treatment settings we deliver ourselves, are they kind of going to get the best? Are they going to reduce the barriers? You know, is it treatment failure, or is it just the treatment setting wasn't suitable for the person? Thinking the environment itself, this is a particularly, like, is this, imagine how sort of daunting these environments, these traditional, I know we all work in the setting of using old crumbly buildings and there, but are the settings we deliver treatment, you know, thinking about lots of different distractions, lots of different sensory, over hypo and hypersensitivities. Someone with when I work with young people with ADHD, I like try to close the blinds because I know if there's birds flying by the window and stuff, they'll be distracted the whole time. You know, can we modify our environments to kind of take into account if we can understand some of the challenges of the person in front of us to kind of maximize their ability to stay in the session one-on-one? And similarly, improving our practice, you know, kind of, these are just some things. This is something we produced a few years ago, looking at that sort of co-occurring stuff, you know. Do we modify what we do, you know, to understand some of the features or the challenges or strengths, you know, kind of things like visual aids, simplifying language, like in terms of the structure, you know, we're not expecting someone to come with sort of an inbuilt ability to fit into our structure. Can we help them externally do that? You know, engaging, can we kind of use less woolly language? Can we be more concrete? Can we be more specific? Can we be more predictable and use visual aids? You know, can we also think positively? Can we not see everything as a deficit? Can we capitalize on those strengths that someone brings, the special interests? Quite often I like to talk with young people I work with on the autistic community about their special interests, about kind of whatever it is to kind of foster that engagement and kind of bring it into the treatment plan, you know. Also kind of, you know, accounting for, as I said, those sensory preferences, the distraction, you know, kind of understanding that kind of one-on-one interventions or standard treatment settings can be quite anxiety provoking, you know, using some grounding techniques or starting off with that before launching into the questioning and assessment and stuff. Thinking about, can we understand, is there any executive function differences in terms of planning, in terms of taking in information that we can account for, and really trying to be positive, remaining the hope. This is no different to anyone who works in addiction. We try and be the ones who hold the hope, you know, positive reinforcement. A lot of people have a lot of strengths. A lot of people, if they're there, are wanting to make a change and maybe feel quite stuck. So positive reinforcing sort of when things do go right, and holding that hopeful approach. I like this approach. Like, yeah, definitely the context as well. But just to reinforce that point, I think clinically we use quite ambiguous language. We might use quite clinical language, and maybe kind of that also we have to understand the context we deliver things. That maybe slowing down and being more detailed, more concrete is a good way to be. Sort of thinking about this is something from that guideline that we produced at Orygen as well. Like this is some very specific thing that backs it up about how you would modify psychotherapy, which might include this space things that are evidence-based in addiction, like CBT, like motivational interviewing, like contingency management, stuff that we deliver, like how you might adapt that or to any kind of therapeutic space. Moving a little bit, this is the whole controversial topic as well. Definitely thinking about ADHD and substance use treatment, that when we do see the co-occurrence, the guidelines, so the ADPA being the Association of Australian Professionals. So this is kind of the peak body in terms of kind of medical, at least, sort of psychiatrists and other interested people, so physicians and stuff, that treatment for people with ADHD and substance use disorder should focus on both disorders concurrently. Thinking of both, consider the interrelationship between what you're seeing in terms of treatment, and definitely try to follow guidelines for each disorder, because we do know there is very few or no sort of guidelines, and maybe there is some principles about co-occurrence that we do follow, and there are some general guidelines. So how do we kind of look at that? I'm thinking about, what is the impact of ADHD on substance use treatment? That one thing we do know. There's no question that individuals with ADHD and substance use disorders tend to have earlier onset of substance use disorders. If they become dependent, have greater risk of ongoing problems into adulthood, and definitely experience reduced remission rates and longer waits for recovery or improvement in treatment. And that those with ADHD and substance use disorders are less likely to progress in treatment and more likely to drop out early, which is another barrier for care. And we do know that offering those who are maybe picked up with ADHD and treated earlier in adolescence tend to have better outcomes in terms of substance use outcomes later in life, and less harms associated. What might be a way? Clinical management of co-occurrence. I mean, this will be depending on where you work, how comfortable you are, and what the service allows you to do, and very much kind of thinking of clinical management. We know that ADHD symptoms like impulsivity, poor planning will interfere with substance use disorder treatment. And we also know that sort of co-occurring substance use, especially mild to moderate and out of control substance use, will limit the benefit of any treatment you do with ADHD. So really sort of no need to say that we need to kind of consider both at once. But how do we treat? This is very much dependent on where you work and what you're comfortable with. But my multimodal approach is always what they would say is the preferred way, that pharmacotherapy being the primary thing for substance use disorder, but if the substance use disorder is not stabilized or is increasing or diversion is expected, really thinking about what type of agents we use. The primary treatment is usually stimulants for ADHD, but the presence of uncontrolled or non-stabilized substance use disorder, being quite wary about that. There is non-stimulant treatment. In fact, even if stimulants are used in the setting of substance use disorder, that the dosage, and I know this has been a big sort of point of discussion in the ADPA in terms of their recent thing about what doses to use, because actually there is evidence of reduced efficacy of stimulants in treating of substance use disorders, but very much the multimodal approach. You can't forget behavioral interventions being the important bit, CBT, MI, contingency management, depending on access. And I put a plug in here as a youth psychiatrist. Do not forget the families, do not forget the carers. They are such an important part of recovery and care as well. The ADPA guidelines are available online if you want to. I'm not actually a member of ADPA, but I can put a plug in for them. I do think they are definitely leading the way in trying to bring together the medical community and providing good evidence-based guidelines. That this is a nice decision flow chart for those of us, and think about how you might treat the co-occurrence, how you might screen as well, which I think is something that I mentioned before we're all interested in, and kind of how you might apply some of those treatments. How can we work together? How do we bring this all together? How do we provide care to this group of people with neurodivergence and addiction? Very much so, some really good quotes, and I'll go back to the original roots of these talks I do is from the autistic community space, and from the UK, the National Autistic Society produced some really good practice guidelines for clinicians and everyone else to follow. And the thing is that important in working with people is working collaboratively. You can work collaboratively. We'll come at you as equals in that and work with you. The right person wants to work with you and understand you if you come at people as equals. And also not to forget diversity. And I think we talked about it before, that people from the autistic community, and there's lots of people from a variety of different sort of that's a spectrum as well. And definitely it makes a big, massive difference, not only to understand someone's neurodiversity, but also to understand their holistic approach of who they are, that it makes a massive difference if you take the time to understand them as a person. And, not one of us owns this, not one of us is the true expert. I think there's lived experience, there's clinical, there's researchers. I think we all own this. There's families, there's everything, there's the people themselves seeking treatment. We all work together better. And I think the more we realize that, I think the better the outcomes will be. And I think given the interest in this talk, the more hope we have for the future. Please do. This is a big area of my interest. I'm very, very happy to hear from anyone, very happy to collaborate. Please do reach out. As I said, we at Orygen are just one very small part of the picture, but very much part of this wave kind of leading for change. And I think the Matilda Centre, Orygen, there's many places out there who are advocating strongly in this space. So thank you for your attention and thank you for coming.
Thank you so much, Eddie. That was fantastic. We've had a ton of questions that have come up and there's no way we're going to get through them all. So what we'll do, as I mentioned before, is we might send the ones that we don't get through to you, and hopefully you'll be able to respond to them, and we'll post them on our website if you're comfortable with that.
Excellent.
However, I will start with just a couple. So a question about if you could comment on what the time frame for abstinence for individuals who are waiting for ADHD psychiatric assessment. Someone currently has a client that has indicated presenting symptoms and was asked to wait for 12 months without relapsing.
Yeah, I mean, once again, I think there's no clear guidelines in this, and I think it's very, very much dependent on who you're working with, what they're comfortable in doing, and what the setting will do. And I think that's quite, and also the jurisdiction that you're working in. I think different states have different sort of legal jurisdiction. I know that, for example, the laws in Victoria and the laws in WA are quite different in terms of kind of what they will let you treat. I think kind of it's more about the principles. And I think what I said before is I think if someone has a co-occurring substance use disorder and ADHD, it does complicate it in terms of kind of understanding the symptoms, because quite often there is that overlap between some of the symptoms if someone has an active or unstable substance use disorder and ADHD. But also if you want to start treatment to manage ADHD symptoms, and treatment in ADHD, unfortunately, they talk about pills and skills, but very much pills these days. I think, unfortunately, is the thing that we do know, that actually the treatment response isn't as efficacious. It is blunted. So the question, if someone's not responding to treatment, is it a dose thing, or is it that it does muddy the waters? So most people, my experience is most people have quite a conservative approach to this. I think sort of 12 months being kind of there. Some people, if they're feel more skilled or in their more specialized setting, might reduce that down to 6 months or 3 months. There's some very rare centers, like I know the Ed Odkin, who's a big person in the field. He has a dual diagnosis clinic in Shepparton that actually treats people with ADHD and co-occurring substance use disorders, currently substance use disorders, but he would be very comfortable, has a setup and has a very much clinic and expertise set up to do that. So he would treat co-occurrence at the time with the view that actually treating ADHD will help people reduce their substance use. But by and large, it very much depends on the practitioner and what they're comfortable with. And I would say that at the moment, that would be the right way to go. Like, you would never ask anyone to go outside of their level of expertise or comfort, because I think the risk is then we all don't want to expose people to harms. I think that's the thing. You don't want anyone to expose them to another harm. That's, I suppose, the big debate at the moment, to treat or not to treat, or to wait or not. And it kind of reminds me, I think back in the day, I remember when I started training, it'd be like, oh, you can't start antidepressant treatment for depression until you're abstinent from alcohol for 2 to 4 weeks. And kind of that was quite a very old-fashioned view and would delay treatment. And more recently, people are realizing that actually treating depression kind of helps substance use. So it's kind of, I wonder, is it similar there? But I think given ADHD and what we use as stimulants as the actual treatment, I think there's this extra layer of concern about safety, about actual regulations, and maybe even stigma or political as well. So I think it's probably a factor of all those things.
Yeah, and working within your capacity, like you mentioned as well. There's more questions about treatment in terms of medication, but I actually want to ask a question which is sort of touching on something you mentioned, which is Kate has asked about a client that she has who was unable to access ADHD diagnosis, and they used methamphetamines for symptom management, and whether that is common.
So yes, so I think clinically, I can say I don't have my I don't know if there's any queer papers out there that have looked at it, but definitely from a clinical perspective, I think it's quite a common it's quite a common thing that I hear, that actually I'm self-medicating with methamphetamine and stuff, and it makes me think clearer. And I mean, I think if you like, I'm not saying this is I would never say this is an intervention, but if you think about it, even just from a logical point of view, I think given one of the main treatments for ADHD are stimulants that are amphetamines. You could imagine that if someone's using some sort of illicit substance that may contain some amphetamine or may not, who knows? It's quite unpredictable in terms of purity, that potentially it could be using the same receptors. So there would be some basis in what they say. I mean, you'd never obviously recommend it as a as a harm reduction strategy, but by and large, I think we would say that's very much so. But then if I took methamphetamine or amphetamine, actually amphetamines, even if you don't have ADHD, do make you focus anyway. So anyone would feel that. So what we would do is maybe embark on that. It's excellent that you've had the thinking about that you felt that you have some symptoms. Let's try and understand your symptoms of ADHD more. I mean, obviously harm reduction, you will choose to use amphetamines or not. We're not going to tell you to do that. But let's look at your ADHD symptoms. Let's look at a time before you used amphetamines to see, were your ADHD symptoms present all the way back there. Let's use that, like, in the brief intervention space. Let's use this conversation as a way to kind of look back in terms of how it's affected your life and what problems it causes you and what barriers it causes for your ongoing care.
And I really appreciated the way, early on you touched on needing to consider why people are using substances and the functional reason it plays in people's lives. It's so important.
Yeah. I think just to plug it, I know everyone's very interested in ADHD, but I do think, oh my God, there's so much diagnosed and undiagnosed sort of autism spectrum out there, and it really does, if anything, at this talk, it really just does create barriers for people to access care and for us to feel confident that we're delivering the right care. So I'm very passionate about that, kind of increasing the understanding of kind of that co-occurrence of neurodivergence and treatment, particularly in the autistic community.
Thank you. And there's still 15 more questions that we haven't got to, which I will send to you. But just so we can finish on time, I'm going to go to let everybody know that they can find out more information about our guidelines, which the webinar series is linked to, and our other resources at our website on screen here. And I'm sorry for those of you whose questions I didn't ask, but I will pass those on to Eddie and ask him to answer those, and we'll post the answers on our website, as I said before. And I want to thank you all again for having joined us for this webinar. If you're interested in viewing this recording, registering for our upcoming webinars, or looking back at our library of past webinars, you can do that at our website. As I mentioned, we'll be having more webinars over the next few months. To find out more, you can subscribe to be notified or keep checking our website. But until then, I wanted to thank you for joining us again. And thank you so much, Eddie, for having done this webinar for us today. It was fantastic. And please, everybody, enjoy the rest of your day.
Thank you very much for inviting me.
Thank you.